Pediatric Core lecture series on NICU chest and abdomen. Thank you for joining us today. There is a quiz at the end of this video, and you can log your attendance at the end of the quiz. So this is the outline of today's lecture, approach to the newborn exam. We'll be talking about technique, what is expected for a normal newborn radiograph. We'll talk about the lines, and then we'll go into parenchymal lung disease, specifically surfactant deficiency, transient tachypnea of the newborn, meconium aspiration, and bronchopulmonary dysplasia. Then we'll go into lucent lung lesions or cystic lung disease, which include CPAM, congenital diaphragmatic hernia, and congenital lobar overinflation. And then we'll talk about lung opacification or dense lung lesions, such as pneumonia and sequestration. And then we'll touch a little bit on newborn abdomen, specifically necrotizing enterocolitis and looking for pneumoperitoneum. So we'll talk about technique. The film should be well penetrated. We should be able to see the dorsal intervertebral discs through the cardiovascular silhouette. The patient should be well inspirated. We should be able to see the right hemidiaphragm below the 7th rib. And the patient should be centered and not rotated to the left or right. The ribs should be equal in length, and the patient should have it be in a neutral position, not exaggerated lordotic or kyphotic views. The clavicle should be around the 2nd ribs. So in this example, the patient is rotated a little too much to the right. The ribs are not equal. The clavicles look asymmetric. So we take that into account when we read the chest X-ray. And in this film, the patient is apical lordotic, so the beam of X-rays is coming in at an angle and giving us this strange view of the ribs, where the rib ends are coming up and the clavicles are really high above the thoracic inlet. So when we look at pediatric films, we don't want to think that they're just smaller versions of adults. Newborn is not a smaller adult. The image is immediately taken as the newborn is just getting off fetal circulation. So we have to think about what physiologic changes occur at birth and how does that manifest on a chest X-ray. You can think of fetal circulation as being similar to adult pulmonary hypertension. So in fetal circulation, your lungs are going to be filled with fluid. You'll have a back pressure of blood into the pulmonary arteries. You'll get vasoconstriction and arterial wall thickening. You'll have a right to left shunt through a patent foraminal valley. You have a right to left shunt through a patent ductus arteriosus, and that in turn will cause a physiologic right ventricular hypertrophy. So you'll see mild cardiomegaly on newborn chest X-rays. So during fetal lung development, the lungs are basically glandular sacs from 0 to 25 weeks. They're filled with fluid. And the airways start to canalize, and the pulmonary capillaries start to arise around 25 weeks. And after 25 weeks, the alveoli start to develop, and we start to produce surfactant. And surfactant is what allows the sacs to open up. So you can imagine that without surfactant, the glandular sacs are not able to open up and fill with air. They'll just continue to be collapsed and filled with fluid. And that will give you the diffuse pulmonary opacities you'll see on chest x-ray. If the lungs are allowed to develop normally with surfactant, they'll continue to expand and they should continue to develop up to 18 years of age. And there's a difference in appearance of the x-ray depending on whether they had vaginal or C-section delivery. If you think about the lungs being a sponge filled with water, during a vaginal delivery, all that water gets squeezed out of the lungs versus a C-section where there isn't that external pressure, and you'll keep that fluid on board in the lungs. And on a C-section, it can take up to 4 hours for that fluid to clear out of the lungs, and that usually will normalize by 24 hours. So what happens to the fetal circulation after birth? Before birth, you'll have lots of fluid in the lungs, and all that fluid will come out. You'll no longer have the pulmonary vascular constriction. You'll have decreased pressure in the right ventricle. And you'll no longer have the right to left shunt anymore. Your foramen ovale and ductus arteriosus will still be open, so you'll have bidirectional flow still between the right and left sides of the system. So you will continue to see increased pulmonary vascularity shortly after birth. And you'll continue to see a mildly enlarged cardiac silhouette. So these things can affect what a chest x-ray can look like after birth. If there's late clamping of the umbilical cord, you'll have increased blood volume in the body, and you'll get longer appearance of cardiomegaly. During increased stress of birth, that will shrink the thymus, and you may see a thymic rebound in the first 2 weeks after birth. And you'll also see up to 72 hours this ductus bump, which is the patent ductus arteriosus. This is an example of the ductus bump. It's to the left of the spine at around T3, T4 level. And it's this opacity here on the left. This is the ductus bump. That's the patent ductus arteriosus. And it's a normal finding in up to 72 hours after birth. Here's an example of a normal thymus. You have the wave sign, which is an undulation of that thymus underneath the ribs, and also the thymic sail sign, which is the thymus just coming out next to the lung. You'll also have a thymic notch sign, which is this indentation here on the right side of the mediastinum, and another example of the thymic sail sign. Okay, now we'll talk about lines. Always use what you can. So if the chart is available to you, it's nice to be able to go into the chart and see what lines the patient has so you can accurately report that in your report. So the endotracheal tube should be midway between the thoracic inlet and the carina, about 1 centimeter below the thoracic inlet or 2 centimeters above the carina. And the nasogastric tube should be in the stomach, in the left upper quadrant, or the feeding tube in the stomach or the ligament of Treitz. PICC line should be at the caval right atrial junction. and also the UVC should be in the same spot. And the umbilical arterial catheter can be in two places. It can be in the thoracic aorta at T5, T10 level, or closer to the aortic iliac bifurcation at L3, L4 level. And ECMO cannulas can be arterial venous or venous venous, and we'll go over that. Here's an example of schematic of the fetal circulation to give you an idea of where the umbilical venous and umbilical arterial catheter should be. Umbilical venous catheter comes through the umbilicus, through the umbilical vein here, and goes through the ductus venosus and up the inferior vena cava into the right atrium. So we'll follow a path from the umbilicus. The umbilical arterial catheter will go from the umbilicus down the umbilical artery and coursing up through the common iliac artery and up the ascending aorta on the left side of the spine. So that's how you'll tell the difference between the UAC and the UVC. Here's an example again of the UAC coursing down first and then making a tight turn up towards the left of the spine of the thoracic aorta. Here's an example of a malpositioned line. It's the endotracheal tube in the right mainstem bronchus. You'll see right lung overinflation and left lung electatic collapse. Here's a nasogastric tube that was placed in the lung. And this is an example of a UVC that is very high. You want it positioned here at the inferior caval-radial junction, but it is all the way up into the right neck. And here's an example of a UAC that looks pretty low. You can see how it courses down first and then up. And this should be near the descending thoracic aorta. Here's an example of umbilical venous catheter that has perforated one of the veins and ended up in the peritoneum. So ECMO cannulas, ECMO stands for extracorporeal or outside of the body membrane oxygenation. So we're oxygenating the blood outside of the body. We're giving the lungs a rest. It is a modified heart and lung bypass machine for severe respiratory distress. And the larger line, the venous line, should be in the right atrium area, and the arterial line should be up higher at the brachiocephalic artery area. And depending on your institution, some of the ECMO cannulas can appear high, but they have a marker down below to show you where the distal end of that ECMO cannula is. It's important to pay attention to where the ECMO cannulas are to make sure they do not retract or migrate. Here's an example of the arterial cannula that has retracted back a little too high. It's almost coming out of the neck. That can be a serious problem. Okay, so now we're talking about lung parenchyma. Two things to think about when looking at a newborn chest x-ray and their lung parenchyma is to think about if they're premature infants or term infants. And the way you can do that is, of course, you can check the chart, or you can see if the humeral head has ossified. And Up to 82% of newborns at 42 weeks will have a humeral head. Before 38 weeks, they usually do not have an ossified femoral head. And the other thing you want to ask yourself is what are the lung volumes? And that will help you guide your differential for what you see in the lungs. So in a full-term infant, you're going to be thinking about meconium aspiration and transient tachypnea of newborn. And in a preterm infant, you're going to be thinking about hyaline membrane disease. And this is also known as surfactant deficiency, also known as respiratory distress syndrome, also known as lung disease of prematurity. So these are all the same thing. Okay, this is an example of meconium aspiration. It's a stress response, and the meconium products cause bronchial obstruction and cause air trapping. You'll see hyperinflation of the lungs, this asymmetric and granular ropey opacities. You may see a pneumothorax or pneumomediastinum or pleural effusions, and usually these can clear pretty rapidly after 48 hours. Along with meconium aspiration for term infants, you got to think about transient tachypnea of the newborn. This is seen mostly with babies that have undergone C-section or near-term full babies. They'll have normal lung volumes. They'll have this streaky perihilar opacities, very linear and reticular glandular to interstitial patterns. You may see a thickened minor fissure or small pleural effusions, and these should also resolve in 24 hours. So this is an example of TTN that is getting better. Initial chest X-ray shows these streaky perihilar linear interstitial opacities, and after 20 hours, repeat chest X-ray looks a lot better. Surfactant deficiency or hyaline membrane disease is due to the lack of surfactant production by type 2 alveolar cells. The surfactant usually starts at 24, 25 weeks and progresses and surges at 35 weeks. Surfactant lowers the surface tension, allowing the alveoli to expand. And what you see with surfactant deficiency is a collapse of the alveoli. You'll see interstitial thickening. It causes epithelial injury and causing appearance of air bronchograms. And these hyaline membranes cause proteinaceous exudate to slough off inside the airways. What you see is diffuse hazy opacities on the initial chest X-ray. You see some air bronchograms, very low volumes because the lungs cannot expand. The incidence, of course, is greater when they're more premature, 50% at 26 to 28 weeks and 25% at 30 to 31 weeks. There's a more prevalence in males and females. And you always have an abnormal initial radiograph. You'll never have an example of a normal-looking lung turning abnormal, and you would not suggest surfactant deficiency in that case. Surfactant deficiency will improve with giving surfactant or corticosteroids, and usually they improve in the periphery first and then centrally. One of the complications of surfactant deficiency is hemorrhage. An example of hyaline membrane deficiency on day 1, chest X-ray looks abnormal, low lung volumes. You have hazy bilateral airspace opacities with air bronchograms. And on day 2 and 3, after administration of surfactant or corticosteroids, the airspace opacities improve. You still have some air bronchograms here. but definitely better by day 3. Improves on the periphery first and then centrally later. So this is an example of meconium aspiration. You have hyperinflated lungs, you have asymmetric granular airspace opacities. This may be a humeral head here, so this patient may be a term baby. This is an example of meconium aspiration. This is chest x-ray. It looks like low volumes with diffuse airspace opacities with air bronchograms. So this is would be surfactant deficiency or hyaline membrane disease. This looks like low volumes. You have kind of this ropey perihilar interstitial opacities kind of radiating out. This I would put transient tachypnea of the newborn or retained pulmonary secretions in the differential. Could be also surfactant deficiency, although I don't see air bronchograms. So this is retained pulmonary secretions or transient tachypnea of the newborn. So complications of positive pressure ventilation. How we treat surfactant deficiency is positive pressure ventilation. So we want to look out for any complications of this when we're treating for surfactant deficiency. There can be a perforation through the airway, accidental extubation. You want to make sure the ETT is in the right place. If the ETT is placed in one of the mainstem bronchi, you can get secondary atelectasis. You can get infections, laryngeal edema, stenosis, and you can get the airway blowout or pulmonary interstitial emphysema, pneumomediastinum, pneumothorax, and pneumopericardium. And another complication of surfactant deficiency disorder is bronchopulmonary dysplasia. Here's an example of, again, malpositioned lines, selective bronchial intubation, causing overinflation of that right lower lobe and atelectatic collapse of the left lung. Here's an example of pulmonary interstitial emphysema, and this is what happens when the ventilator pressure exceeds the tolerance of the alveoli or ducts and ruptures and starts to dissect along the interstitium. And you'll see these fine, linear, radiolucent streaks extending into the periphery, and they kind of progress to round and cyst-like radiolucencies on later exams. They can be lobar or unilateral or diffuse, and they kind of if they travel towards the hilum and decompress, they go into the mediastinum and they present as a pneumomediastinum. And if they travel to the periphery and decompress into the pleural space, they'll become pneumothoraces. Another example of pulmonary interstitial emphysema. You can see these fine linear lucencies throughout the lungs, seen here again. And we want to look for pneumothorax. They can be subtle, they're not always this obvious. Look for any sharp or mediastinal heart borders. Look for the deep sulcus sign, suggestive of a pneumothorax on a supine chest radiograph. Usually one of the hemithoraces is going to be more lucent than the other, may suggest pneumothorax. Examples of pneumomediastinum. This is where the air is tracking into the mediastinum. You may see a lifting of the thymus, or a Spinnaker sail sign, or angel wing sign, this is known as. So lifting of the thymus, that's abnormal. And you can see on the left here too, this angel wing sign. And on the lateral view, you may see pneumomediastinum gas in the mediastinum a little easier than on the frontal radiograph. So what is going on here? This is a 4-week-old preemie that is ventilated. We have high volumes. We have coarse interstitial lung markings. This patient probably had surfactant deficiency. They got intubated on positive pressure ventilation. That may have caused some pulmonary interstitial emphysema. And now at 4 weeks old, we have high lung volumes and this chronic coarse interstitial lung markings. This is an example of bronchopulmonary dysplasia. So bronchopulmonary dysplasia is also known as chronic lung disease, and it can happen when premature infants are oxygen dependent at 4 weeks, and you'll see chest abnormalities. It's barotrauma from prolonged ventilation support with large tidal volumes. Causes airway inflammation, septal fibrosis, and hyperinflation. You'll see ill-defined course, linear reticular opacities, interstitial thickening, focal air trapping, and hyperinflation. With bronchopulmonary dysplasia, patients will have increased risk of RSV for the first 2 years of life. You may get regression of linear opacities and lucencies, but you always have this kind of scarred appearance in the lungs. You'll get residual hyperinflation, and on CT you'll see multifocal areas of hyperinflation, linear scarring, and this triangular subpleural opacities. So this is a continuum, these three entities. The risk of bronchopulmonary dysplasia increases if surfactant deficiency is complicated by pulmonary interstitial emphysema. So patients with surfactant deficiency get treated with positive pressure ventilation, which may cause pulmonary interstitial emphysema, which can lead to bronchopulmonary dysplasia. Okay, now we'll go talk about cystic lung masses, or the lucent lung. Your differential is going to be congenital diaphragmatic hernia, congenital pulmonary airway malformation, and congenital lobar overinflation. So with congenital diaphragmatic hernia, you'll see the abdominal contents herniating through a congenital diaphragmatic defect. You may see stomach, or small and large bowel, and liver herniating up into the chest. 90% of these are going to be on the left. Most of them are going to be posterior, called a Bach-Dulac hernia. And the prognosis depends on the amount of lung that can develop when the chest cavity is filled with something other than lung. And you may see appearance change over time with serial imaging because of the bowel peristalsing. You'll see air-filled structures in the hemithorax with the mediastinal shift, and indistinct hemidiaphragm, and scaphoid abdomen just not filled with bowel. This is an example of congenital diaphragmatic hernia with the herniated stomach. The lungs are allostatic, and you can see a shift of the midline structures towards the right. And you may see bowel loops starting to appear. Same patient, lungs are a little better inflated. You now have air going through the intestines, and you'll see bowel loops in the left hemithorax. You'll see cystic structures on the right side. Could be a congenital diaphragmatic hernia, but your differential would now include congenital pulmonary airway malformation. Congenital airway malformation, there's 4 types, technically 5. But what you have to remember is type 1 is going to be the most common. It's going to be the large cyst greater than 2 centimeters. Type 2 is going to be associated with abnormalities such as renal agenesis, tracheoesophageal fistulas, and intestinal atresias, congenital heart defects. And then type 4 is going to be associated with pleural pulmonary blastomas. So congenital pulmonary airway malformation is failed bronchoalveolar development, anywhere from the trachea to the distal airways. It retains the communication with the tracheobronchial tree, but the airway is abnormal. You'll see fluid-filled spaces on the initial first films that increase with air on follow-up films. They'll appear as multicystic pulmonary masses, usually involving a single lobe. So this is an initial chest X-ray demonstrating a left lung mass opacity. And on follow-up films, that opacity fills with air. So you need to be thinking about a congenital pulmonary airway malformation. The workup for congenital pulmonary airway malformation is a CT scan at 3 to 6 months of age for surgical planning. If the lung lesion is suspected prenatally on ultrasound and radiographs look normal, I would get a CT to confirm. And your differential for opacity in the lung includes sequestration, congenital diaphragmatic hernias, bronchogenic cysts, or cavitating necrosis from pneumonia. And with CPAM, you can get a hybrid lesion with sequestration. So you'll have both entities. You'll have a congenital pulmonary airway malformation that gets anomalous arterial systemic circulation or sequestration. So you get a CPAM sequestration hybrid. Here's an example of CPAM type 1, large cysts, right lower lobe. Here's another example of congenital pulmonary airway malformation with cystic lung lesion in the right lower lobe. And this is an example of congenital lobar overinflation. Presents the neonates with respiratory distress. Initial chest X-ray appears normal, and then you have an increasing size of a pulmonary lobe after birth. Usually it occurs in the left upper lobe, and then the middle lobe, and then the right upper lobe in frequency. You'll get a hyperlucent enlarged lobe without much cystic change. This is what it looks like on CT. You just get an overinflation of a single lobe of the lungs. Usually it occurs in the left upper lobe, then middle lobe, then right upper lobe. Consolidated lung lesions or opacified lung, we'll talk about neonatal pneumonia and pulmonary sequestration. Pneumonia can be life-threatening. Can be acquired during perinatal period via the placenta or the maternal vagina from strep B infections, most commonly, and then staph or E. coli. Can be from prolonged labor or premature rupture of the membranes. A fever and white blood cell count are not reliable signs of neonatal pneumonia. Usually it is can be diagnosed radiographically. What you'll see is patchy, asymmetric coarse opacities with hyperinflation, alveolar opacities in air bronchograms. And these findings can overlap with surfactant deficiency and transient tachypnea of the newborn, and possibly also meconium aspiration. You just have to think about it in your differential. And these can present with pleural effusions. And pulmonary sequestration is a congenital area of abnormal lung that does not connect to the bronchial tree or the pulmonary arteries. There's two types, the intralobar and the extralobar. Intralobar, the pulmonary venous return, the venous return stays in the pulmonary circulation, so you get pulmonary venous return. With extralobar, it's outside of the lungs, so you get venous return is going to be systemic, usually into the IVC. And it has a propensity for the lower lobes, left more than right. Again, there's going to be an abnormal pulmonary arterial supply, so you get systemic arterial supply, and these can present as a hybrid lesion with congenital pulmonary airway malformations, and you can evaluate this with a CT angiogram. So again, opacity in the lung showing up on CT and radiograph. You can see on the CT a systemic arterial supply straight into the aorta. This is a 3D representation of pulmonary sequestration. The sequestered lung showing up as a clear mass here on the 3D representation, showing number 3, showing the systemic arterial supply, and then the pulmonary venous return into the pulmonary vein there. Okay, quickly we'll talk about newborn abdomen. Main things we'll go over is necrotizing enterocolitis and looking for pneumoperitoneum. So necrotizing enterocolitis occurs with very low birth weight, premature infants, and they present with bloody stool. You'll see bubbly and curvilinear lucencies and mottled lucencies throughout the abdomen. You may see portal venous gas over the liver because that pneumatosis intestinalis will travel back in towards the liver. You'll get portal venous gas, and you'll get perforations causing free air, looking for pneumoperitoneum. What you'll see is possibly asymmetric bowel dilation, some featureless and unfolded bowel, some tubular looking, straight appearing bowel, maybe separation of bowel loops or fixed bowel loops over serial films. And in these patients, an enema is contraindicated for the risk of perforation. An example of pneumatosis intestinalis, you can see these curvilinear lucencies kind of outlining the bowel wall in a patient with necrotizing enterocolitis. And more examples of pneumatosis intestinalis, this curvilinear lucencies outlining the bowel wall, kind of a mottled appearance down here. And you can also see it with bowel ultrasound, this pneumatosis intestinalis, which suggests necrotizing enterocolitis. can see these hyperechoic appearance to the bowel wall with shadowing. You want to look for pneumoperitoneum, or this is from bowel perforation or an air leak from the chest from ventilation, or could be post-op, which usually clears in 24 hours. What you want to look for is the football sign, and that is what you see is the falciform ligament outlined by the pneumoperitoneum over the liver, or Wriggler sign, which is seeing air on both sides of the bowel wall, and usually a left lateral decubitus view is used if pneumoperitoneum is suspected, and you'll see this lucency overlying the liver, suggestive of a pneumoperitoneum. And I just want to touch on esophageal atresia real quick. This is an initial chest X-ray demonstrating a what's supposed to be a nasogastric tube that's stuck at the thoracic inlet. And if you see this on an initial chest X-ray, you want to suggest an esophageal atresia. And because this patient has air in the stomach and bowel, small bowel, there's going to be a distal fistula. So this is an esophageal atresia with tracheoesophageal fistula.